My name is Dr. Ira Kirschenbaum. I am the editor of the Journal for Orthopedic Experience and Innovation. Tonight we have an amazing lineup with Dr. Alexander Saad, Dr. James Womack, Dr. Yair Kissin, Dr. Eytan Debi. And we are going to be talking quite a bit about robotics in general and very much specifically about the early experiences with the T-Mobile Mini, sorry, T-Mini. Obviously, it's mobile. There's no question about that. The T-Mini robot. And I think it's great. I would like the panelists to introduce themselves, where they're from, and we're going to ask more about their use and they'll talk about their history with robotics after the introductions. So let's start with Dr. Saad.
Thank you, Ira, for having us. Look forward to having this discussion. And I do hip and knee replacement in Fremont, California. I started using robotics about 3 years ago or so, various platforms. And I have really been impressed by the many benefits of the Think robot that we'll talk about this evening, and look forward to talking more with the other panelists.
Excellent. Excellent. Dr. Womack.
James Womack. I am out of Clinton, Missouri. I do general, but a focus in total hip and total knee. Have been doing robotics for going on 7 years now. Have really been excited about kind of the changes that I've seen over the past 7 years, and I'm really excited about the TMINI and the benefits that it has over some of the things I've used in the past.
Excellent. We're going to go to Yair Kissin.
Hi, good evening, everybody. Thank you guys for having me. Always nice to talk about something you really like and believe in. I'm a knee surgeon exclusively over in Hackensack, New Jersey, and been using robotics since about 2017. Was part of that original, the bigger robot called T-Solution 1 from Think, and transitioning to the Mini using that technology to put it in a handheld device is something we've been waiting for a long time, and it's here, and it's pretty exciting to talk about.
Excellent. Dr. Debi?
Hi, everyone. I'm Eytan Debi. I'm a hip and knee replacement surgeon at HSS in New York City. Thank you for having me tonight. I'm also a hip and knee replacement surgeon. Have been using robotics both in knee and hip replacement for quite some time now, both in my training as well as in practice. I think that the TMINI robotic system, I think, is an exciting new system on the market, and I think differs itself significantly from other options out there. And so I'm really looking forward to kind of discussing it here today and answering any questions that may come about.
This is great. So I'd like to start off by asking the panel, and I'll call on you guys at random. What do you feel are the current problems in robotics? Initially, my questions used to be, should we use robotics? That's an old question. So what are the current problems in robotics? Maybe we'll start with Dr. Debi.
Sure. I think that you can discuss that for a very long period of time in terms of what are the problems, and it depends on how detailed you want to get. I think that the problems I see them in my practice is being able to use a certain robotic system with whatever implant you want to use. And I think right now we're very much married from a certain implant with a certain robotic system. That's the biggest high-level issue I found in my practice. And beyond that, there are certain kind of little details with each robotic system that you can say this can be improved on or made better. But to me, as a whole, that's been the bigger issue in my practice. So let's say I want to use a certain implant system. I don't want necessarily to use the same robot of that system. Gotcha.
Dr. Kissin, some comments on that? Agreements or
I agree completely. It's hard to get two Israelis to agree on something, but yes, no, absolutely, I agree with Eytan. But I think the part for me is getting the result that you want while not disrupting your workflow too much. And to me, I'm very passionate about not upsetting my staff. We're blessed with very excellent staff, and our staff oftentimes is not excited about being in the robot room. And we have a Rosa, we have a Mako, and we have a T Solution One in our hospital, and now we have the TMINI. So for ease of use, I think that's really, to me, that's the goal for me, is to do a total knee replacement that's been working quite well for some time, and adding this technology, and not disrupting the way we do it too much, because I think that's been the challenge for a lot of surgeons to jump into robotics, is the all the novelty of it and changing the way they do things. So if you don't have to change it too much, you don't have to move people around to different parts of the table so that there's line of sight. If you could do the operation close to what you're normally used to doing it with some enhancement, and that's what I feel this device gives us, is that bullseye, to give us a little enhancement for an operation that works really well without robotics, but let's try to make it work with this technology that we'll hopefully all be using soon.
Dr. Womack, what are the current problems in robotics, and how is Think solving them for you a little bit?
Well, definitely. Thanks for having me on. And I completely agree with the guys who have spoken to this. And I think my perspective from a smaller hospital, one is access. I mean, access to a robot if you're in a smaller community, smaller hospital setting. The cost, I mean, cost can become preventative at times. But I think that T Solution kind of solves both of those issues with it being available. It's a smaller footprint. And I completely agree with Yair when you don't disrupt your normal OR staff. They can still do their job the same way. It's not a big leap from doing a manual total knee to implementing robotics with the TMINI. Still allows you to have your normal workflow and really not upset the OR staff or the time constraint on your total knee. But I agree completely. It takes a good procedure and gives you a lot of information and allows you to be very reproducible to make a good procedure a great procedure.
Great. And Dr. Sa from Northern California.
Yes, well, I agree with what all our prior panelists have said. They've really nailed it right on the head. Certainly cost, the footprint, the stress on the staff to do new procedures. And really the biggest issue right now is if you're a high volume surgeon, doing robotic procedures often take more time, longer turnover. If you're in an ASC, you don't have that footprint or the sterile processing of various, I mean, it just makes everything more difficult. And unfortunately, we're not getting reimbursed more for doing robotic type surgery. So, and if we are, it's very, very little. There are some codes, but very, very small. It might make us better surgeons for some of us. It might let us do better and give our patients better knees, perhaps. But if you're a high volume surgeon, you're doing 10, 11 joints a day, you're doing an ASC, robotic technology in its current form just don't allow you to do that. And as our reimbursements are going down, we have to do more volume. And we really need a robotic solution, something that lets us get the soft tissue balance, the accuracy of the implant placement. We need something that will allow us to achieve the goals of traditional robotic surgery, but with a more friendly product for the surgeons to use, a better tool. And again, something that the surgeons have on this call have touched on, something handheld, something with a lower, smaller footprint, something easier to use that does not disrupt normal workflows. I think that's really the benefit of the device we're talking about tonight, TMINI.
Excellent. I want to comment first. If anybody has any questions or comments, please put them in the chat. There's just too many people for me to see hand raise reactions. So put a question in the chat. I'll call on you to answer your question. I'll always interrupt the speakers even at the flow to get your question answered. So I would like, we'll stay with you for a second, Alex. Talk about your history with robotics in general, because there was a time in your career you didn't use robotics. So
something changed. You're absolutely right. So why would I even do that? Because I'm doing about 1,300 joint replacements a year. So we're very busy. We need efficiency and turnover, and something like a robot that took more time on me and my staff was just not doable. But if the technology was letting us do better knee surgery or giving patients better outcomes, I thought it was something that I would at least have to try. And so that's when I first went into it. We have since used various CT protocol robots. We've used imageless type robots, trying to see which would work better. And again, as fast as we can be with them, it's still a challenge with time. And so we want to make sure that we're giving our patients the best results possible, but not interrupting our typical workflows. But really, I went into it, Ira, because I felt it deserved attention, because I think there are definitely some benefits from it. Really, it's interesting when you look at robots. I think when they first came out, people were saying it was better accuracy, right? It was putting the implants in better. It was millimeter cuts or degree changes. But I think we've slowly learned that while all those things can help, a lot of it is the objective data we can get in terms of implant placement, maybe soft tissue balancing or inventory, knowing what implant we're going to use before we start the surgery from pre-op planning and the CT-based imaging. I think those are all the benefits of efficiencies and where robots can help. It's just, can we make the actual procedure faster, more seamless, more efficient in modern joint replacement surgeries, where, again, we have to do a lot of them high volume and in ASC settings.
All right, great. Dr. Kissin, you have every robot under the sun except for Robbie the robot from Lost in Space at your hospital. So talk to me about your history of robotics, because we trained at the same place. I think I trained at least a week before you. But at least you weren't using robots again. I'll ask the same question. And then something turned the glacier. What was it?
I think, yeah, no, I remember a time when I thought it couldn't possibly get any better than, my training from the absolute masters of knee replacement. We knew what we were doing, and this was the one way and only way to do knee replacement, was a cemented PS knee with a patellar resurfacing every time. And at the same time, you start actually reading the literature and seeing that 10 to 20% of patients aren't happy. Even some of my own patients weren't happy. And so I was wondering if there was a way to maybe get some kind of smaller bullseye and get this operation more precise, more personal to the patient. And I think once you can do pre-op templating in these kind of devices that we have available to us, whether it's the autonomous robot or now with this mini, I think what I saw was that we're actually not just doing, it was actually an anesthesiologist who looked at me and said, "How do you know you're cutting that at 5 degrees of valgus on the end of the femur?" And he said, because it's bobbling around, that distal femoral cut. And this was the anesthesiologist over the drape. He's absolutely right. And we probably shouldn't be cutting everyone at 5 degrees of valgus and everyone at 3 degrees of external rotation. And we're probably not actually cutting. That's not even the result we're probably getting. So to Alex's point, where we're actually getting what we think we're getting or what we're aiming for. And then secondarily, when the plot graph was kind of shifting a little bit about not just constantly going for the 0-degree mechanical axis, where we're shifting a little to a gentleman's varus or a kinematic, or God forbid, an unrestricted kinematic. There has to be some way to objectively measure where you're doing a good job or not just putting it wherever these guesses. You have to take the guesswork out. And I think these machines are allowing us to do a mechanical axis, perfectly straight knee, a little bit of a skewed knee, or all the way to different philosophies that are out there. And no matter how you do it, as long as you're doing it in a way that actually looks like it's working, where you see a plot where the knee is balanced and it's moving well and the patella is tracking well, I need a machine to tell me that that's the case. There's so many ways we argue about how to do it right, but this is maybe letting us actually know that we are.
There's two comments on what you said. One is I'm amazed your anesthesiologist got away from reading Field and Stream to make a comment at all. And the second, I'm amazed that you listened to him. But we'll move on to Dr. Debi. Okay, and what is your history with? What's your history with robotics, and when did it click, Eytan?
Sure. So I came to the field of orthopedics, I think, after doing, a lot of more research and development in robotics. So I actually have a PhD in biorobotics and bioengineering and mechanical engineering. And it's that excitement that drove me to then go on to do an orthopedic residency. So I've had a passion for technology in the OR and in implant design for a long time. And I mean, thankfully, even in my training, the robots, at least for knee replacement, were already on the market. And so it's really almost been a kind of, and I'm almost like of a different generation in terms of how I was trained. I definitely did plenty of manual knees. In fact, that was the majority of my training. But already, I would say at the end of my training, robotic knee replacement was becoming very fast. I would say the vast majority of the newer surgeons were switching over. And I think that it clicked for me, I think early on, where I could see how it almost became part of my education. So I was learning the knee replacement, not just in terms of the standard alignment techniques that Yair mentioned, but beyond that, discussing, the actual cuts we're making, the thicknesses of our implants, what are the implant thicknesses based on the robotic designs, what does the trochlear groove look like based on a certain implant design, and suddenly we're thinking about the knee in such a more complicated fashion as compared to where we started. So that's where my passion begins. And from my standpoint, I've been using robotics in my knee replacement since I started practice. And I don't use it for all cases. In some cases, it's not available, or I'm using a certain implant system that doesn't have a robot that I can use for that system. And so I'm not 100% robotics because of that. And I think that's one limitation. But when I do kind of switch back and forth, every time I come back to the robotic knee, I just have that kind of sense that I feel like I'm getting a better understanding of what I'm putting in a certain patient at the end of the day. Now, whether that makes a difference clinically, I mean, I think we have a lot of studies out there, and that's part of my research, but I really do think eventually it will matter.
That's excellent. And Jim, what's your history with robotics?
So in training, where I trained, where they were kind of early adopters of navigation and used some of those numbers to look at alignment and things. And then that kind of, went away. And I did manual knees for my first 5 years out in practice. And as I did more and more, difficult knees, I started to think, okay, how can I make this better? What could I do to maybe give myself an edge as far as looking at the alignment, looking at how contracted is this? How could I make this an easier operation for the patient to get over, let alone their soft tissues and all those things? And so I kind of started looking into robotics, and the more that I looked into it, the more excited I got about the information it gave me, the information I could glean from doing a preoperative plan and deciding what my implants were beforehand, and really looking and planning that surgery before I ever walked in the OR. So we started robotics going on 7 years ago. Have really transitioned, and then really kind of took it up, and now I probably do about 95% robotics.
Wow.
Certain times insurance doesn't cover it, whatever reason, and so we'll do a manual knee. And I still love doing a manual knee, but at the end of a robotics case, I just love that feeling of knowing where I put my implants, knowing that it's reproducible, being able to look at that and see, okay, yep, the trochlear groove's right in line, and I feel very comfortable that what I am trying to achieve, I'm achieving. Whereas kind of like Dr. Kissin had said earlier, before, how do you know exactly what you're cutting? Well, we didn't. We had a pretty good idea, but like we said, this gives us the opportunity to be very precise as well as reproducible. And I do think it's a much nicer operation on the soft tissues. I think being able to cut one time and be done, as well as not instrument the femur and do some things like that, I think it's beneficial to the patient.
Excellent. And then all of this makes sense. Again, if you're having any questions, just put them in the chat. If you don't know how to do that, then I cannot help you. Okay, so we'll leave it like that. Let's talk. We talked about robots, and we have a robot in our facility, a large robot that is heavier than we'd like, probably. So I'm going to ask the big question: why the TMINI, especially if you have experience with a previous, I'll call sort of having a foot plate that's the size of a Cadillac. Why the TMINI besides just the size? Why the TMINI? I'll stay with you, Jim, first.
So I think a couple of things there. One, I mean, you nailed it on the footprint, right? Especially if you're operating in multiple rooms, Trying to move that thing back and forth from room to room becomes difficult. Storage also becomes difficult at times. The TMINI, it gives you the opportunity to have a very small footprint. A lot of my cases that I do are myself and a tech. I don't even have an assistant. You're able to run the machine yourself. You are not dependent upon another person in the room to run the computer or run the robot. So I think that helps significantly. And also I think having the handheld is a very easy transition that if you're normally doing manual knees, this doesn't really get you out of your workflow. You're still putting in pins, you're using traditional guides, but you have robotics to put those pins exactly where you want them. And so I think it's a very easy transition for guys who have trained either manual or guys like myself who've done both, and you feel comfortable doing what you were trained to do. You're not relying on this big footprinted machine to kind of guide you in everything you do. So I do feel that it benefits. I like having the control of the robot in my hand versus it kind of controlling me. So I think all of those are benefits for it.
So I'm going to switch gears a little bit. Alex, I'm going to show a video. I just want to see if it comes up. So let me just bring that up for a second. I'm going to share my screen. Share screen. Okay. Could people see a PowerPoint? Good.
We can.
All right, I'm going to play a video first, and maybe Alex, you can sort of take us through what we're seeing. If you're not seeing the video, I didn't start it yet. I did start it. Can you see the video?
No, yeah, we can see it.
Yeah, good.
Great. So I'll try to narrate this video. And I think some of the highlights you'll see, number one, is the setup. You can see the unique overhead field of view. This is different than our typical robotic systems, which really is a huge improvement because it doesn't matter where the assistant is on the other side of the table. You can see the arrays are pointing upwards. So with this active tracking and the unique overhead camera system, there's no line of sight issues. You don't have to have your assistant dodging, ducking, playing twister, trying to get out of the way so the camera can see the arrays. Here you can see it's overhead out of the way, so it's really always in the field of view. Similarly, the registration tool you can see here is also angled upwards. It's very ergonomic, fits your hands well. It makes registration very quick and simple, as you can see. Very similar to other systems, but just very fast. You can see you have larger fields of view and points to register much quicker. Very easy and simple to use. It's like playing a video game. It's very natural. I think for people who've already done robotics, it's simple. And if you haven't, it's very easy to adopt as well. And then with the technology, you can see on the screen on the robot, it will tell you what the plan is. And then here's the handheld device. You can see that it stays in plane, and it's only, I don't know if you can see on the video, but while I'm pulling the trigger, it only turns on, it only spins when it's in the exact right plane. So if I deviate out of that, it will turn off. But you can see no matter how I hold the hand piece, the actual device knows where to go. So it places the pins where you want it so that the distal cutting guides can go exactly where you want to. So the nice thing about this, Ira, is these are all steps that are familiar to a surgeon, right? We're used to having the saw in our hand. We like to make the cuts. We know when we're making accurate cuts or not. But this is putting the instruments we're used to using in the exact right position. Where we planned it before surgery, based on CT planning, we can make any changes we want to in that CT plan beforehand. We can make adjustments during surgery. But these blocks basically allow us to use the standard cutting jigs that we're used to with that implant company. And as prior panelists have said, because there are multiple implant systems on this platform, you can choose what system you like, you can choose what manufacturer you like, or what philosophy you like. And it's all very easy to use with this technology. You can see handheld. Again, on the tibial side, it places the tibial cutting jig just in the right place so that it's an accurate cut every time. I think to answer your question before, I read the simplicity of this, really this would have been the ideal robotic platform to come out first. I think it's somewhat of a shame that these more complicated, larger machines came out first because it completely changed surgeons' workflow. You had to learn a whole new way to do surgery, taking the tools out of our hands. Here, you're doing the surgery how we were trained, how we know how to do it with familiar instruments. So this robot's really probably more a robot for the masses, where the very tech friendly surgeons have already adopted bigger robots. I think they will look at this robot as a way to be more efficient and do more surgeries faster. And I think those surgeons who have not yet adopted technology will be very interested in this, because this puts that robotic technology in their hands, in their ASCs or wherever they work.
We have a question from Thomas Cumming. Thomas, you want to ask your question? I don't know if Thomas is on. He asks, why offer a different robot an opportunity? I guess you sort of answered that in a sense. I'll ask our PhD amongst us, Eytan, Debi. So what do you think about this science? If you were developing a robot in your lab based on your robotic biomechanic PhD part of your life, what do you think about that?
I think that there's a lot of new technologies coming out every single day, and I think that we're only at the tip of the iceberg as to where we're getting with artificial intelligence and ability to plan the case and personalize our knee replacements. What's interesting, I completely agree with what Alex said about, it's kind of this, shame, I guess, that this system didn't come out first. But to design the system and plan it, I think, for better or for worse, just took longer. And in a weird way, it does take us back into using some of the old but pins and cutting jigs. Not that those are old, but it takes us back to some of the more standard instrumentation, which I think in some respects makes robotic surgery easier to adopt. And so from that standpoint, I think it is very nice in terms of making it a little bit easier for new users to see how it all works. I think one big benefit of the TMINI from my standpoint has been the open platform nature of it. There's so many knee replacement implants out there, and I think we each so many people here in this group, not just the panelists, but all the audience members, I'm sure, have certain knee replacements that they like. They may have different knee replacements for different patients that they like. They may have metal allergy issues that they're concerned about. They may think about different liner options that they like. And the idea that, we have to get used to, like, I'm a Mac user, right? But, I have to use my PC at work. I don't like that, right? I just want to use my Mac and just do everything on my Mac, right? So I think from that standpoint, there's this idea that why should, if a knife is a knife, let the surgeon use the knife, which would be our robot, and let us do whatever we want with the knee replacement itself. And so it is a little bit challenging when I think implant manufacturers necessarily are isolated to robotic development. And I think having a technology company and a robotic company focused only on robotic technology and improving robotic technology, I think really opens up doors. And I think this is the first step towards, building out even better, surgical robotics moving forward.
It's excellent. You comment on it, and it reminds me of a sort of a line that if I was to have this technology first, if this was the very first robot that came out, do you think anyone would build a big footprint robot? It's sort of like if I came to you and I said, I have this new invention, it's called film, and it goes into a camera. Would you get rid of your iPhone camera because of that? So I wonder, if this came out before any other robot, do you think this would be the standard, or would people still go down the other route?
In my opinion, Ira, I think they would be the standard, just because all the hurdles of these traditional robots, these first generation robots, they're very challenging. And that's why only so many people can afford them, have them, place them, use them well. If you had something that was lower profile, easier to use, could be used in an ASC or main hospital setting, there's no question I would think there would be much greater adoption, especially for surgeons where there are multiple groups of people using different implants, to have a system where different surgeons can use different implants on the same robotic technology. that's game changing. As Dr. Debi alluded to before, having a robot in a hospital system and you can only use their implants, great for the implant company, but not great necessarily for the patient or the surgeon in terms of their choice of individualizing and really personalizing the surgery for that patient. So I think you're right. I think if this had come out first, this probably would be the gold standard.
Fascinating. I want to, there's a question from one of our great frequent flyers, Trevor T, who is having a little trouble with audio. So I'm going to ask this question. Maybe we'll flip this question over to Dr. Kissin. First, it's a multi-tiered question. People can see it in there. Could you share with us a little bit about the learning curve first, and then about the return on investment? Let's talk about the learning curve first, Yair.
So yeah, I mean, we definitely looked at learning curve on the big robot, on the T Solution one. We actually published with Will Long in the group that did that, and it took about 10 cases to get to a time that was it wasn't time neutral with manual, but there was a period of time. And learning curve is a funny thing, right? Learning curve with an anterior hip means you make you don't have such great outcomes for the first 100 hips. There's been no essential learning curve here. There's no complication that we added to this procedure by learning how to use this robot. But just to basically piggyback on what Alex said before, this takes an operation you know how to do many, many hundreds or thousands of times, and it really just guides it like a GPS. And you ultimately, a knee replacement is just placing 6 pins in a knee, 2 on the tibia, cut the tibia, 2 on the distal femur, cut that, 2 for the rotation, cut that. And this is basically that pin guide. So the learning curve is pretty rapid. And I mean, I was fortunate enough to do it a bunch in the lab, but when we just started using it over at Hackensack last month, it literally became such a thing where the group of techs who did the in-service the week earlier wanted to come in to see it, and it was the case was done. They were next door doing another case, happened to be one of the bigger robot designs, and their case was over. They came in and we were closing already. They missed it. Blink and you miss it. So this kind of turns into the situation. It's very interesting what Alex brought up before, but I think it's really important to not forget that this is technology that has been built over platforms of RoboDoc and the big Think robot, now streamlined to this. So I don't know if it would be possible to come right to this. That would be a pretty big leap. I think having the history. I'm a history major. I like history, and there's history here where the thing worked accurately, but like it has been said, it wasn't adopted. There were reasons that people wouldn't adopt it. They had to change the learning curve of the big robots, and I've used 3 of them. You know, it's a lot. You have to move things around, move people around. The only learning curve here, I think, for let's say non-robotic users, is placing pins, which I personally I don't let a resident. Some of my residents are on this call, and I love you guys, but I won't let you put a pin in a bone, because if you don't put it in the middle, then you will have a learning curve that is undesirable. And registration. And I've done registration with a couple of different devices. And this one, like Alex said before, really easy. It's just fast and easy. So that's a little bit of a stretch for somebody who's not robotically inclined yet, but it's not a big one. And once you learn how to do that, we all know how to put pins in bones. Registration, some nuance there, but then the case is really not that far off from time neutral pretty quickly, in my experience.
So I'm gonna go back to the second part of Trevor's question in a minute, but we have a guest from down under, Josh Petterwood, who is a classmate of mine. And Josh, you're on if you want to. Curious about quantifying soft tissue laxity. You have some questions. Where are you, Josh?
Hey, sorry, it's David North here. I actually work with Josh.
It's David. Yes. Okay.
How you doing? Yeah, I guess the adoption of robotics down in this part of the world has been extraordinary. About 40% of our knee replacements across the country are done with robotics and navigation prior to that. I think the big thing we get back from surgeons is it's less about the cutting almost and more about the soft tissue quantification and perhaps better implant positioning and all of the nice things that come with that. Just curious on I guess people's views on that and perhaps how the TMINI addresses that, having not seen it down here.
So who on the faculty or not faculty want to take that about the role of robotics and better soft tissue assessment?
So I think I can speak to that a little bit. Well, there is a section once you've done your registration, you have a section of the procedure where you do load the soft tissues, and it gives you your gaps. It gives you your ability to kind of know, okay, are we lax? Are we varus? Are we valgus? And load those tissues before you ever cut. So at that point, I think it does give you the idea of, okay, do I want to change this plan a little bit? Maybe I am more contracted than I expected, and I want to move the femur up or maybe bring the tibia down. So by having that section of the procedure where you literally are loading all the ligaments in any direction you want, and it can tell you about your soft tissues, it can tell you about your alignment, your contracture, and it really does allow you to change on the fly if you want to make a change. Also, it gives you real-time assessment of what's happening with those tissues. After you've made your cuts, you put a spacer block in there, you're able to reassess those gaps, reassess everything, and see if you've truly gotten what you wanted. And so I think it's a very good tool to do that. And I think it makes it very, very easy with not only the numerical numbers on the screen as well as a graph that kind of shows you where you're sitting at what point in flexion and extension.
That's excellent. I think we have another user online. Dr. Peterson, are you available to give your experience? I don't know if you're still on.
Yeah, hey everyone. Thanks for this great panel.
Hey, Don.
Hey, it's good to hear from some of y'all other people who've been using the TMINI. It's been a great tool in my hands too. It's just like everyone said, I've used several different robots, and this one just fits into your workflow so easy. It's actually funny, I'll put the pins in, I'll put the blocks on, then I feel like I'm ready to bring in a giant robot or something, but it's like case is over, you just got to cut it and you're done. So it's been a good tool for sure to add to the armamentarium.
Yeah, I know.
And
Go ahead. Sorry.
sorry, I just wanted to add that I think to answer David's question from Australia, a lot of robotic usage down there, and I think that the challenge that for a lot of users, they don't have access to robotics. And so having a handheld, easily adoptable technology like the TMINI will put more robotic technology in the hands of the vast majority of surgeons. I think the CT planning, the ability to really be precise in where we're going to put these implants will get most surgeons most of the way where they want to be. And as Dr. Womack was saying, really can help us balance our needs better. But to answer your question further, the TMINI 1.1, which is under FDA review currently, is pending 510 clearance, which will give that gap balancing soft tissue adjustments live during surgery. So I think that's what you're asking about, David. That is coming, as currently under review. But I think that's going to provide surgeons that last bit of information they want, which is intraoperative dynamic soft tissue balancing. It's being reviewed.
That's excellent. I'm going to cold call on somebody because I see that he's here. I hope he's still on. Corey Calendine, most famous orthopedic surgeon on the internet. Do you have any comments about this technology, Corey?
Listen, I'm really enjoying visiting with you guys. I'm actually just stepped out of the shower, but I'm listening with interest. I apologize for the picture, but it's better than what you would see. Listen, I'm with what Dr. Shaw just said. I'd love to hear some of the gap balancing. I thought the comment from Australia was brilliant. I think it's the data and the information we're getting about the soft tissues that people desire. So I'm certainly anxious to see how this all plays out.
That's great.
Thank you.
Thanks, Corey. I really appreciate it.
And Ira,
Yeah.
it's Sean Gibson from Think. I would just share with the team. So TMINI right now in its current FDA clearance, what we've done clinically, doesn't have the air quote gap balancing, which isn't what we would message for the technology itself, but the I would call it intraoperative flexibility. That was just submitted to the FDA this week and is pending clearance. So if anyone has interest in what that software does, in addition to what Dr. Saw narrated earlier, you can reach out to marketing@thinksurgical.com, and we're more than happy to walk you through a demonstration of that software. But we believe the combination of that intraoperative flexibility with the handheld nature and the small form factor of the system, we're more than happy to show you a demonstration of what that technology can do.
Great. So we have thank you, John. We have a and that link was just put on a chat for that. We have another part of the question from Trevor, and that is, how much would you budget in money and time in adopting this technology? You know, it's sort of a complex question to kind of get off the fly, but you know, it speaks to what you recommend for small clinics, certain size hospitals, or any hospitals. But as far as budgeting, what are we talking about in numbers here? You know, because we're in an open mic session, so we could talk loosely about that. Does anyone want to take on that one? We could.
Can I? So I mean, a little bit my thoughts on some of this, and I'm not an economist, but certainly we have to become junior economists as orthopedic surgeons. You know, I love using one particular system that has so many options that I can go from a uni to a hinge, you know, if I wanted to, right? But you pay for that. You pay for these premium systems in the top 3 or 4 companies, which have great lines of products. There's also a midfield, and some of the midfield players, you know, have an opportunity here to maybe in certain neighborhoods or countries or regions break into a place where maybe a hospital can't afford the premium systems, and you know, they're excellent products, they're excellent knees, and they work very, very well. They have some really great technology behind them, and it's nice to be able to offer options that you can still use a robot for. So I think this gives you a unique open door to have options for companies that have really, really good lines, but maybe don't have the means to spend millions of dollars and many hours to develop their own robot. They don't have to. Here's one that they can still be robotic and then enhance the way that their particular knee system is working, and that can really be a money saver for a smaller hospital, or maybe a country, you know, that they don't have access to this kind of stuff that we do.
Or maybe even a community hospital like special surgery, right, Dr. Debi?
Yeah, that's right. You know, I think thankfully we have a lot of robots at our institution, but each one has been a huge event to purchase and get through. And it's not, it may seem like, you know, we have a lot, but each one always is a very big challenge in terms of purchasing. And each one, every time you have another, it's another big hurdle. And I don't want to speak to our institution specifically, but and from a larger picture, you know, going back to Alex's saw originally of whether this came first, you know, from an economic model, if such an open platform robot comes in, then suddenly another robot comes in and says, "Oh no, we only do this one implant," and that's a tough pill to swallow for a medical system, and even a small community hospital. So, you know, I think that there are a lot of other robots out there, and I would say, you know, each one has its you know, pros and cons, but I think from a financial standpoint, it would make sense that an open platform robot would be a lot more beneficial in terms of the medical system as a whole. But every specific system is, you have to assess what your needs are, what your uses are, and you just have to kind of do a little thorough assessment of what your needs are for each robot.
And hey, Ira, it's John again from Think. I would just offer, if anyone's interested in the ROI and the cost of the Think robot, if you could again please email marketing@thinksurgical.com. And the only reason I say that is, to Dr. Debi's point, reimbursement models and so forth are important in terms of assessing that ROI. There is a capital cost involved, but I think what Dr. Debi was alluding to, right? As health systems adopt one single robotic system that's tied to one implant vendor, I think it's important to note, right? The open platform gives freedom to choose to the surgeons, but also provides a level of competition in those RFPs and so forth from that perspective. And so that's really what we're looking at, right? Is choosing a robotic technology that gives the precision in the bullseye that Yair mentioned earlier, but also not secluding yourself to one single implant vendor that may not be healthy or willing to come to the table when your health system needs to discuss the different financials that is necessary to make it cost effective for robotics.
There was a question by Tyler Hart, who doesn't have a microphone, probably because he bought one of the other robot systems and doesn't have money to spend on a Logitech microphone anymore. Sorry, Tyler. But what are the economic thoughts or challenges for pre-op imaging? And as things move towards the ASC, do the logistics and economics make this pre-op imaging issue a barrier? Does anyone want to take on that question? Could be one of the faculty or not. You know, how do you get pre-op imaging done when pre-op imaging is not paid for necessarily?
So I haven't had an issue yet, other than maybe one or two patients. I've had patients tell me that they would be, if you really believe in the technology and you want what you think is best for the patient, I've had patients be willing to pay out of pocket, and it's a CAT scan is really not that expensive. Even in North Jersey, it's a couple of $100. So it doesn't actually end up being prohibitive. Cost aside, for me personally, I'm an advocate for the CT based pre-op planning, because that's what gives us that accuracy. We haven't really focused much on the accuracy because we're kind of just assuming it's there. And without that pre-op planning, in my personal opinion and my experience using some of the imageless technology, you're basically doing navigation. In my hands, that's how I feel when I do it. And the people who can make it work, good for them, and I'm sure that they do a great job. But for me personally, I think part of the bullseye is that CAT scan, and without that, I don't know that this works, or any technology works as well. And this isn't the only platform that uses a CAT scan preoperatively. I think that hospitals are happy if I'm ordering a CAT scan, because there's some downstream revenue then from them purchasing a robot. So kind of everybody can win here. And if the CAT scan ends up being an out-of-pocket expense, I mean, if you want certain enhancements on your car when you get it, you'll pay for certain things out of pocket. And if you want your knee, if we can tell patients confidently that we think this is better for them and this is going to enhance their outcome, which has yet to be definitively proven, but at least many of the people here do believe that we can prove this, and just in our own experience think that that's the case. I think that it's not going to be a problem.
So I have a final question. If I was a new startup joint replacement company and I have a new joint that does something I think better than elsewhere, what is the process? And maybe someone from Think Surgical could answer, so maybe one of our panelists. How do I, as a new joint company, what's the process to get Think Surgical to connect to another company? Because you can't just use the open platform means that a company has a relationship with Think Surgical, correct? That's right. So what's the process? Does anyone want to talk about that? If I had joint replacement company X, I was just curious about that. Like if I was
Yep.
using joint company X and I want to say to them, hey, I want to use the TMINI.
Yeah, hey, Ira, it's John again.
Yeah, great.
I'll take it away from the surgeon faculty here. Our vision is to be open platform, and we will accept and work with any company that wants to be on the platform. And that's because we believe freedom of choice is important in the clinical decisions for surgeons and patients. Right now, we have 4 FDA-approved partners: United, Innovis, TJO, and Ortho Development. We have 5 other partners that have signed collaboration agreements. We are open to anyone that is interested in being on this platform and being a part of that empowerment of choice for physicians. What I would ask is if there is an implant company out there that wants to be a part of this, any small or large companies, what we'd like you to do is, again, email marketing@thinksurgical.com. We have a vice president of business development that will connect with them, and we're more than happy to start a collaboration agreement with them that makes sense. But again, our plan here is to be a robotics company, not an implant company. Our value is providing a standard of care through robotics and then enhancing all of the options through implant technology that are out there through all of these innovative orthopedic implant companies that are on the market.
Excellent. So we have about 5 minutes left. I want to share one screen that I will show. This, of course, is the Journal of Orthopedic Experience and Innovation, Joey. If you go to our page where it says CME, you could reflect on what you saw tonight and go through some sequence and get on a pathway of continuing education credits for anything, Joey. So even if you read any of our articles in the journal, this is, in my experience, Stefan Kreutzer. You can go to this, you can read this article, you can go to CME, you click here. All our CME is free to everybody. So you could even do it tonight when you hang up and get some CME. Even if you just coming out of the shower, you can do it, you know. But just don't take any pictures while you're doing it. Some final comments from each of you. I'll give you guys each a minute. All right. We'll start with Dr. Sa. Some final comments.
Yeah, just really enjoyed this discussion. Thanks for the opportunity. I recommend those who are listening to demo the product if you haven't seen it. I think it really speaks for itself once you get it in your hands. It's really quite user-friendly. Anyone who's used virtual reality, it really feels similar to that, just the tactile feel. It's really easy to use. We talked about learning curve. There's really no learning curve, as Dr. Kissin was saying. It's really how quickly can you get to time neutral. And in our early experience, it's been anywhere from 5 to 10 cases, your time neutral.
All right. Dr. Womack.
So once again, thank you guys very much for having us tonight. I've really enjoyed it. It's been a great discussion. I'm extremely excited about the TMINI and I think the open platform design is very novel, and I think it's where everything needs to be headed. As far as the robot, we've been doing cases now for a few months, and really it is very easy to use, very much not a learning curve much at all. I think we were kind of like Alex said, 5 to 7 cases we were time neutral, and now are honestly a little bit faster. So I think it's definitely, it can be a game changer for any operative room that doesn't want to disrupt your workflow, does not want to anger your staff. It's very easy to transition, and I'm extremely excited to use it.
All right, Dr. Debi, a few comments at the end.
Sure. Thanks for having me. I think, the open platform topic, I think it's hard to find someone who doesn't agree with that idea. So I would say that from that standpoint, if that's something that interests you, I would come see the product, see see what it feels like, get a very clear understanding of what a small footprint it has in the OR. I think that's becoming such an important aspect of what we do. We're moving to surgery centers. ORs are getting smaller. We're trying to move faster. You start bringing in, a small Mini Cooper into your OR every time you want to do a total knee. It's a really big challenge. And then try draping that thing. this is just totally different. It's a total departure from what we are right now for robotics. And for sure, like Dr. Womack, Dr. Sa said, from a usability standpoint, it's very ease of use. And if you come to one of the next major orthopedic conferences, and obviously we have some great ones. The TMINI can be there and give it a try, and see what it feels like, because I think you'd be very impressed.
Dr. Kissin, you want to bring us home?
I mean, I would just say that for the first time after doing robotics for a while and just wondering why more surgeons aren't doing robotics, but it hasn't really been a wonder to me, is that the staff, the group, the team is actually excited about doing the case robotically. And if you are not a robotic user, this can very much be a gateway robot for you to really not make a big jump from how you do things normally. And if you are a very well-versed robotic user, you might find that you might possibly like this even more, or have some technology here that you didn't have before that is giving you the result at the end of the day of what we want to hit. And even no matter how you do a knee, whether it's CRPS, UC, MC, all of those different options, we still have good results with this because we all do it differently, and we're still seeing good results. We're still hitting the target, and this is a device that lets you do that easily.
Excellent. So first, I'd like to thank our sponsor tonight, Think Surgical. It's pretty obvious, but thank you tremendously. The staff at Joey, Elizabeth Best, Lara Wynn, Erica DeLeon. We love putting these on. Anyway, I want to say thank you to everybody, and I appreciate our amazing panel tonight, and the time you spent is really, I'm very honored. Thank you.